Good morning, afternoon, and evening based on when this is viewed. I'm your host, Dr. ShumayouDutta, and today I'll be sharing uh, the outcomes of endoscopic disc debridement, antibiotic bead insertion, and percutaneous fixation in cases of infective spondylodiscitis. So I'll be sharing three cases today. So the first one is a 62-year-old male who complained of severe back pain and bilateral radiculopathy. The pain scores were 10 out of 10, both for the back and leg. This patient was bedbound with an ODI of 88. Neurology, there was weakness in L4 and L5, grade 2 out of 5, both lower limbs. This patient is a severely moribund patient with a bed sore, diabetes, hypertension, atrial fibrillation, CKD, liver enzymes elevated, bilateral Krebs, total count of 42,000, anemia, had a history of UTI a month back, 2 weeks back, had pneumonia, sepsis, and seizures. And this was his MRI of the lower back. You can see that there's infective spondylodiscitis with severe stenosis, and his CRP was 270 with a hemoglobin of 7. So, given that the number of comorbidities, our anesthetist was very hesitant to give any form of general anesthesia, and our options then remaining were empirical antibiotics, a CT guided biopsy, or disc debridement and decompression and fixation under general anesthesia. But since general anesthesia was contraindicated here, or the risks were too high, the other two options also don't seem good enough. So instead, what I had done in this case was I planned a two-stage procedure. And the first stage, it did a disc debridement endoscopically, transforaminally under local anesthesia. Here you can see my trocar is in. Then after a thorough debridement using curettes, antibiotic beads were placed inside. These are calcium sulfate crystals with vanco coated, and these follow the zero kinetics, which means there is constant release of antibiotics at a very graded level, and it's very good for the outcomes. And I left a drain in place. Cultures were sent. This patient started doing very well with respect to the back pain. The leg pain still persisted, but he was very happy. He started moving around. 1 month, we achieved the source control. We got a good culture sample. The risks of general anesthesia were not there, and obviously, we achieved pain management. 1 month post op, when he was much better, we planned him for fixation, and MIS TLIF was done percutaneously, where again the disc space was debrided and bone graft was put in. Now he healed. Subsequently, he healed very well with absolutely no complications. Another case of L34, again a CKD patient with a lot of comorbidities. L34 spondylodiscitis, early stages. You see, there's not much end plate erosion here. So just went in with the transforaminally with the endoscope and did a disc debridement and placed antibiotic beads in there, and this healed subsequently uneventfully. And the last case is a two-level spondylodiscitis, where you see there's active infection in both levels, and the end plates are completely worn out with the infection having destroyed the end plates. So I did a two-level endoscopic disc debridement under local anesthesia and antibiotic bead impregnation, and following which you can see the endoscopic port. Did a MIS fixation where I took paraspinal ports and used open implants to reduce the cost, and this was done. And this patient also healed very well. So all in all, three cases, three good outcomes. Very complicated cases with high risk of anesthesia and very CKD with a port inside, and we achieved good source control. We got a good sample from cultures. Patient was not exposed to general anesthesia. Pain management was very good, and all in all the cases healed. Thank you.